Okay, hello everyone. Thank you for joining me on today's lecture, where we're going to discuss a laboratory technique where we're trying to distinguish between a true IgE-mediated hypersensitivity and a non-IgE-mediated anaphylactoid reaction, which both present very similarly. We have symptoms such as erythema, angioedema, and pruritus, but the difference is whether or not IgE is involved. Um, we're going to be using or discussing ELISA because it has the capability of detecting analytes such as antigens and antibodies. For our purposes, we're going to be discussing the specific IgE testing, which is the gold standard in its application for our specific purposes, true IgE versus non-IgE mediated reaction. Before we get into more depth on the mechanisms behind ELISA, I just want to spend a moment to discuss the two main regions when we're looking at a single antibody. So on the screen, we have two separate antibodies. And if we disregard the text, we can see the top portion of the antibody, which is represented by two binding sites. We call this the antibody, or rather the antigen binding region, denoted as uppercase F subscript AB. And at the lower part of the antibody, where there are just two blue strips composing the binding site, we call this the FC region. And the FC region is really important because while if we're able to bind to an antigen, but we have nothing else on the other side of the antibody to sort of mediate an immune response and communicate with the other chemical signals to mediate the immune response, it's all pretty useless. So we need both of these binding sites. So now we can go ahead and begin discussing the different ELISA research protocols. To reiterate, it's used to detect and quantify soluble substances, as I just mentioned, antibodies and antigens. In our case, we want to see whether or not IgE is present. We'll get to that in a little bit. On the screen, there are four main techniques housed under the ELISA method. We have direct, indirect, competitive, and the sandwich method. We're going to be discussing all of these methods except for the competitive ELISA method. And one last mention before we get into the meat and potatoes of these subtypes of ELISA is the enzyme-linked antibody. And the whole purpose of the enzyme-linked antibody is to be able to quantify how much analyte we have. And enzyme-linked antibodies are synthesized in the lab, so we know exactly what they're intended to bind to, but that's not what makes them special. What makes them special is that they're able to interact with different substrates to either change color or emit some kind of light that can be detected on spectrophotometry. And usually the substrate is colorless, so it's really easy to detect these changes. It's also really important to note that it's always the last step where we're introducing this, because if we introduce it in an earlier step, it's really easy for it to get muddled with all the other antibodies and potentially even antigens that are present in the serum or urine. So we want to give that enzyme-linked antibody as best a chance as possible to interact with the substrate, so we have it as the very last step, so it's on the surface, and there's more surface area for it to interact again with the substrate, if you will. So now jumping in, the most simplest subtype of ELISA, which is the direct method. In the direct method, that's very straightforward. We can just coat the bottom of the well with an antigen, and then we'll introduce the enzyme-linked antibody. And then after that, we'll go ahead and wash. If the enzyme-linked antibody binds to the antigen at the bottom of the well, we can introduce substrate, and then we can go ahead and quantify this, how much light we have, and that will tell us how much antigen we have, because that enzyme-linked antibody is directly bound to the antigen. If we don't get any change in color or light, then that means all of the enzyme-linked antibody was washed away because it had no chance, or it had no capacity to bind to the antigen, and we get a negative test. Next, in the indirect ELISA method, this is really used to detect antibodies. And it's best to describe this with an example. Two of them could be used for HIV detection, and also it could be used for detection of Lyme disease, whether or not a patient, we can use this as a confirmatory measure to diagnose a patient with Lyme disease. So first, or rather, when a patient has Lyme disease, it would make sense that their immune system is mounting a response to fight off this antigen. And to do that, it makes very specific antibodies to do that. It doesn't just use a willy-nilly any antibody. So we can use that to our advantage and specifically seek out these antibodies that are used to fight Lyme disease. And the bacteria responsible for Lyme disease is Borrelia burgdorferi. So if we can isolate, or in a sense isolate the antibodies that are responsible to fight this specific bacteria, then that means the patient is fighting a disease induced by that bacteria. So we'll go ahead and coat the bottom of the well with the bacteria, Borrelia burgdorferi. Then we'll go ahead and introduce the patient serum onto the plate, and we'll give it some time to interface. And if the patient is in fact positive for Lyme disease, we expect the patient to have antibodies against the bacteria we just coated the well with. We'll go ahead and wash, and finally we'll follow up with the enzyme-linked antibody, which is lab synthesized and has a high specificity for this antibody that goes after this Borrelia. We'll go ahead and follow it up with a wash again, and well, not hopefully, but just for our purposes, hopefully we have enzyme-linked antibody binding to the antibody that's used to fight Borrelia. We'll introduce the colorless substrate, and we'll go ahead and see if we get any color change or light emission. And if we do, that means that the patient is positive for this bacteria-fighting antibody, so we can go ahead and diagnose them with Lyme disease. And this same principle can be used for HIV diagnosis as well. Finally, in the sandwich method, we're primarily interested in looking for antigens, and this is in contrast to the indirect method where we were interested in looking for antibodies. In the sandwich method, we're gonna go ahead and start and plate the bottom of the well with the antibody that has the capacity to bind to an antigen of interest. We'll go ahead and add some kind of sample like serum or urine. And if the serum is positive for the antigen, we expect it to bind to the antigen coating the plate. We'll go ahead and wash. And finally, the last step will be with the enzyme-linked antibody. And again, just as in all these examples, we'll go ahead and wash, then add the substrate and see whether or not we have some quantifiable amount of light or color change. And on a final note, I just wanted to reiterate the importance of introducing the enzyme-linked antibody last, because again, we don't want it to get muddled with all the previous steps. And if you know that the very last step of all of these subtypes of ELISA was the introduction of the enzyme-linked antibody, then these methods, direct, indirect, and sandwich, become really straightforward to navigate. If you have the direct method, well, the only step prior to that was what it's binding to, the antigen. In the indirect method, if the last step was the enzyme-linked antibody, we know that because it's looking to detect antibodies, the second step must be another kind of antibody. And in the sandwich method, the antigen is literally sandwiched by the enzyme-linked antibody. And if the enzyme-linked antibody is always the last step, then the first step must be an antibody, and the second step must be the antigen sandwiching the antigen. Okay, now we'll be moving on to a practical application of the ELISA test. This is an example from another one of our lectures in which a patient presented to the ED with Ludwig's angina. And we'll go ahead and just quickly recap this. We have a 20-year-old patient with prior medical history of acute periapical periodontitis. They complain of difficulty breathing and swallowing. They've had a previous infection with MRSA, and it's been progressively worsening, breathing obstruction over the past 6 hours, with the initial symptoms starting 2 days ago. Fever was developed on the day of admission, and CT report reveals diffuse swelling in the submental space. During the examination, the patient collapses and they're rushed to the OR. For treatment, the patient's given a large IV bolus of vancomycin. Again, penicillin isn't used because of their history with MRSA. After 1 minute, we see the classic presentation of what looks like mast cell degranulation, erythema, angioedema. And given the context of this treatment setting, we're pretty sure we're dealing with red man syndrome, but we want to be sure. Again, the context is we're giving them a very large bolus of vancomycin, and we know that this is a key drug or key antibiotic that can cause this. Here's a quick explanation of red man syndrome. It directly binds to the mast cell and it degranulates. It's bypassing the IgE, so it's considered an anaphylactoid reaction. Now, the patient has been seen, and after 1 day, the incision and drainage of the abscess was successful, but the providers wanted to make sure that it wasn't a true allergic reaction and that it was a drug-induced anaphylactoid reaction. So blood is drawn and it's sent to the lab. Now that we're in the lab, we discussed in another video, or we discussed that we had the 4 subtypes of the ELISA reactions. Because we're interested in the presence of IgE, we want to use the indirect method because that's the only one that's capable of detecting antibodies. So first, now that we have the blood sample in the lab, we're going to want to go ahead and centrifuge it, and we'll let it clot to isolate the serum. Now we're going to go ahead and coat the well of the plate with vancomycin, and we're going to go ahead and introduce the patient serum. So in the diagram, that orange dot there would be vancomycin, and that orange antibody would be IgE if it were present in the patient's blood. It may or may not be, though. So once we add the serum and allow all its contents to interface with the vancomycin, we'll go ahead and follow it up with a wash. And at this stage, if there was no true allergic reaction, then we would only expect to see only the orange dot. There would not be any orange antibody, and there would not be that black enzyme-linked antibody either, because we haven't introduced it. But if it was a true reaction, we would see both orange pieces, the antigen and the antibody. Now, following the wash, we're going to go ahead and introduce the enzyme-linked antibody, which is specifically made to bind to IgE. Again, if the patient is not suffering from a true IgE reaction, it will have nothing to bind to, and we'll just wash away after a wash. We'll go ahead and wash, and after this, we'll introduce a substrate for which we expect the enzyme-linked antibody to react with. We'll go ahead and follow that up with spectrometry, and in this case, we see no light, no change in color, so that means there was never any IgE specific to vancomycin introduced in our testing, so that means that their reaction was in fact an anaphylactoid reaction, and it was not a true type 1 hypersensitivity reaction, even though they both manifested themselves exactly the same. And that's it for this lecture. Thank you for watching.